Thank you for visiting my website www.drbasari.com. Today we're going to discuss predicting mortality from publicly available data. There are several data sets of publicly available data. One of them is the National Health and Nutrition Examination Survey. It's a program of studies designed to assess the health and nutritional status of adults and children in USA. The survey is unique in that it combines interviews and physical examinations. Thus, on the physical examination portion, for a period of time from 1999 to 2001, arm and calf blood pressures were available along with calf circumference measurement. Therefore, an ABI could be calculated. Patient could be separated into PAD or no PAD based on established ABI cutoffs. This data is easily available for download in various formats. In addition, linkage files to mortality data are available. The software used for the analysis is R and RStudio. Quoting from R's website, R is a free web software environment for statistical computing and graphics. It compiles and runs on a wide variety of Unix platforms, Windows, and Mac OS. The tools we use for analysis are free. The data is free. The method we use in this particular analytic is machine learning random forest method. Random forest is a classification method that is based upon a decision tree. A random sample is drawn from the data. Various features are used. Each of the features uses a node to split the data. The positive response is going to the left of the tree. Random forest is basically an ensemble method. It was promulgated by Breman in 2001. In an ensemble approach, it can be thought of as a nearest neighbor predictor. The main principle behind this is that weak learners get together to become strong learners. In this classification method with random forest, the outcome is predicted using a test data set, or using a training data set. In a mortality analysis, the outcome of death would be predicted. In the test data set, the outcome is known, thus the accuracy of the prediction can be tested. Whether the tree is correct or not would be determined by a voting method. Those trees that are voted as being correct are kept. This method is then reiterated. Thus, a forest of decision trees develops. Each of the trees may pick up on a variability of one aspect of the data. Random forest is very good with missing data, but is not so good with predicting beyond the scope of the data. The features used in our random forest model are shown here. Age in years, body mass index, calf circumference were the important predictors. In this random forest model, after reiterating and coming up with the smallest effective model, age, calf circumference in centimeters, and body mass index, peripheral arterial disease were important features. Here's a receiver operating curve of the random forest model using the four features. The diagonal line going across, if the red line lay along that line, this would mean that our model is the same as flipping a coin. The more to the left and the more up the red line goes, the better the model. This is a pretty good model based on the appearance of the red line on the ROC curve. Using the model, we could predict. Thus, age, calf circumference, centimeter, body mass index were used. Peripheral arterial disease status, if known on a data set of patients, if these four factors are known, we can predict those who are at an increased risk for death. How does this help? We can use data from electronic health record, generate a list of patients with these four features known, and then using this mathematical model, we can predict which of these patients would die. Thus, we would identify our highest risk patients. These patients can then be brought back to the office to see if their treatment meets agreed upon guidelines. We recommend that we should use such tools to the best of our ability to help our patients out. We are in the process of developing and posting on the web a tool that will allow an individual to plug in their own data and obtain the prediction of outcome. Our intent is not to become the person's physician, but to empower them to discuss the risk with the personal physician. Additionally, physicians, hospitals, healthcare groups could submit to us data that they wish to be analyzed using this model, and we can return to them their highest risk patients clearly identified. They could then develop various approaches to help these patients out. Thank you once again for visiting my website, www.drabasali.com.